Hi, it's Sarah. In this tutorial, we're actually going to focus on the CNA Code of Ethics Value Statement number 1, which speaks specifically around providing safe, compassionate, competent, and ethical care. In this presentation, I've actually just updated the information, primarily utilizing the updated Code of Ethics, as well as adding some additional relevant research. So the goals for this week is to discuss the Code of Ethics, the Value Statement 1, and to identify our own developmental needs within this particular value statement, and also discuss the idea of ethical fitness and how this is achieved. It's something really quite important to us as nurses in terms of our overall ethical self-care as well, and to look at what are some of the different structures that can actually limit our autonomy and contribute to some issues with regards to moral and ethical dilemmas. The one thing I wanted to point out to you before we move on is in the Code of Ethics, please take a look at pages 29 and 30 for examples of questions that will support ethical reflection for each stage of the decision-making model, specifically to Oberle and Raffin model. I think you might find this really helpful, particularly, again, in support of your the application of a model for your scholarly paper regarding an ethical issue. So I did want to point that out to you because I think you'll find it really an excellent resource. Okay, so carrying on with the Code of Ethics. The Code of Ethics, as you know, was just revised here in 2017 through a really extensive consultation process with nurses right across the country. And what the Code of Ethics, so this is for registered nurses right across the country. And what this does is helps to make specific and articulate clearly the values that nurses are expected to uphold, to inform the public of what they can also expect from nurses. And looking at in terms of even for individuals that are thinking about entering nurses, what are some of the aspects that really apply to us in terms of our Code of Ethics. Additionally, all of these documents come together and inform part of the various frameworks, if you will, and guidelines and resources that can guide our ethical practice. Ethical practice is also very clearly outlined in the College of Nurses of Ontario Entry to Practice Competencies for the Registered Nurse, particularly the competencies 75 to 86. And I'll just point out a couple of them to you here that talks very specifically about such competencies that would be an expectation for all registered nurses is that the entry-level registered nurse demonstrates honesty, integrity, and respect in all professional interactions, provides care for clients while demonstrating respect for their health and illness status, diagnosis, life experiences, and cultural beliefs, practices, and health choices, supports clients in making informed decision-making, and advocates for clients or their representative, especially when they are unable to advocate for themselves. So it really looks at the whole notion about really as for the entry-level nurse, these are some of the competencies that we expect specifically in terms of overall practice. The additional guide that we also have available to us is the College of Nurses Ontario Ethics Practice Standard. So as you're aware, there is within our professional standards, our 7 professional standards, ethics is one of the professional standards. But there's also a very specific standalone ethics practice standards that really speaks very much to our interactions with clients, as well as the commitments we have not only to our clients ourselves, but also to our other colleagues and our practice settings. So the CNA Code of Ethics, the Entry to Practice Competencies, our professional standards, as well as the ethics practice guidelines are a wealth of resources that allow us to really reflect upon and to evaluate our ethical practice as registered nurses throughout our career. So really what we kind of look at this is value number 1 is really the foundation of practice and the goal for nursing. So look at it. You know, the goal for nursing really is to provide safe, compassionate, competent, and ethical care. And if you look at it in terms of the variety of the ethical lens and theories that we've looked at over the course of the several weeks, you can see how all of this applies. There are some specific laws that guide our practice, such as the Nursing Act, the Regulated Health Professions Act, the others that we discussed in the context with regards to law, privacy acts, things of that nature, criminal codes. Really look at the whole notion of competency and safety, our obligation to minimize harm. The compassion is terms of to recognize sufferings in others and how do we engage actively and to alleviate that suffering. And look at that, the whole notion about ethical practice with regards to our fitness to practice, and also looking at the areas in terms of how we can actually identify preemptively ethical scenarios and actually engage in preventative ethics. So what we're going to do is we're going to kind of pull all these concepts apart and kind of tackle them one by one. So when you look at the whole notion of just about what does it mean to be competent, or what is competency, the definition from your text is it is the integration of knowledge, skills, abilities, and judgment when enacting the delivery of care. So without the notion of competence, yes, mistakes can happen, and there is the potential, obviously, then for patients to be harmed. So hence the reason of looking at what does good practice look like, and that's, again, really what we utilize in terms of our College of Nurses standards, the CNA Code of Ethics, and the entry to practice competencies. Those are the guidelines, the documents, the indicators that actually determine competence and competency in terms of nursing practice. So it's not an objective, it's not very subjective. There are some very objective natures in terms of what is competency. Sometimes some shades of gray, but it is then our ability as registered nurses to be able to clearly articulate, again, what was the knowledge, the skill, and the judgment used when enacting care. So in looking at all the notion in terms of, safe care is not only just that cognitive domain of practice, but also the psychomotor skills, the use of technology, how we competently utilize all the resources we have available to us, and the notion about continued competency. As self-regulated professionals, as you're aware, through the College of Nurses of Ontario Quality Assurance Program, there is an expectation that we continually reflect on our own practice and that we are accountable for our own practice and for addressing our ongoing professional development needs. So utilizing the practice standards as an opportunity to reflect on practice and really maintaining that knowledge acquisition continually throughout practice. You cannot say that your employer doesn't provide in services or your employer doesn't provide those opportunities. That is not sufficient. As knowledge-based professionals, there is the expectation that we will do that as a self-directed individual. So the expectation that, that looking at how do you continually update your knowledge, reflect on practice to ensure that your practice is indeed competent, safe, ethical, and compassionate care. So there's different ways of viewing competency. And there's a variety of ways, and we can kind of look at, so how are these measured based on the lens that's being provided? So obviously there's the notion about what we discussed in terms of law and ethical care. There's some very specific pieces of legislation that identify what is good practice, bad practice, everything from the criminal code to things such as the Professional Health Information Privacy Act, the Nursing Act, the Regulated Health Professions Act, what's a controlled act? What are controlled acts that are authorized to nursing? What is the legislation that provides us with that? Then there's also our professional or regulatory guidelines. So from the College of Nurses, in terms of practice standards, the expectations around the assignment of the appropriate care provider. So the 3-factor framework is an example. The professional standards, all those indicators that are included in those various standards and guidelines are what are deemed to be deemed to be acceptable practice. So from those particular areas. There's, from an organizational perspective, in terms of, depending on your employer, what determines competency is, are you fulfilling your role description? Are you fulfilling and adhering to policies and procedures? Do you provide good care? In terms of looking at competency. There's the public perception with regards to what constitutes competence. So the public's perception about what qualifies as good care, and their perception is their reality. What they deem to be excellent care can vary from patient to patient, but it is their perception that can lead to things such as perhaps not so complimentary letters being sent to the CEO of the hospital you work in that will describe either what they perceive was really bad care, what people were not competent, or hopefully on the flip side, when they felt that they've just received exemplary care and from a notion of competency. And the other area that we can't forget is our own personal self-assessment and self-awareness of our own ongoing competency. As a new graduate, your competency will continue to grow and evolve over time, but also throughout your entire career. So differing views of competency, and again, how are these measured? These all apply to us as nurses, and some we have control over, some not so much. So again, it's really understanding that competency comes from a variety of perspectives, some very, very black and white in terms of the legislative piece, but as you get further away from legislation in terms of regulation, organizational, and then from the public perception, it becomes much more, I'll say, shades of gray. So something for us always to be aware of in terms of where are the areas that are describing what competency means, and am I aware of even what those are? So our competency obligations is really obviously what we want to do is strive for the highest quality of care and to be as clinically competent as we possibly can. We'll touch upon a little bit later, the recognition of our own level of competence, and that will change. And that will change not only throughout the course of your career, but also recognizing sometimes when patient populations change, even new pieces of technology that might be introduced into your work environment, to really understand that the fact that our goal is obviously is to minimize harm, but competency is also understanding where our own values are, our own perceptions in terms of patient care situations. And we also have an obligation to take preventative or corrective action to protect our patients from unsafe, incompetent, and unethical care. And this is itself sometimes creates, as we saw in Kathy's story, the moral dilemmas or moral distress that not only Kathy's actions caused, but those of her colleagues by not taking corrective action, and the implication that had in terms of the harm that was experienced by that patient. So really considering yourself as nurses, relatively new in the program, it's also really considering your own readiness to practice and what do you feel are the limits of what you can honestly do safely. And I will tell you that for some students are very self-aware and very self-attuned in terms of what they can feel they can take on safely. Sometimes we have students that are just a little overconfident, shall we say, in what it is that they can actually do safely, and sometimes get a little bit more excited about the opportunity to actually engage in a skill versus really reflectively thinking, am I actually safe and competent to perform this skill? And really, having that self-reflective conversation, for you at this particular point in your career and your education, what are the key elements of ethical practice for you at this particular point, and how do we go forward? And I'm just going to point these out to you as we kind of go out through the course of the rest of the presentation here. These are the actual statements within the CNA Value Statement number 1 and some of the indicators of what is included in the Code of Ethics. So specifically with regards to this particular area, there is an expectation that nurses are honest and take all the necessary actions to prevent or minimize patient safety incidents. And we also learn from near misses or good catches, as we prefer to call them. And again, an indicator number 6 really looks at that nurses practice within their own level of competence and seek out direction and guidance as appropriate. That is an expectation. That is an indicator of providing ethical, safe, competent, and compassionate care. So what is safety? Well, harm can be subjective, as we know. So I'm again looking at the whole notion of cultural safety. I'll take you back to Nicole's story in terms of, from the experience of Nicole and her family. Was there culturally safe care provided in there? And I think we can argue quite clearly that there was not. The whole notion about, the really preserving the dignity and self-worth of individuals, their spiritual safety. So really looking at the whole person as in a complete and total entity. And also the whole notion about the nurse's own personal safety. My own personal dignity and self-worth, but also my physical safety. And part of that is also about the workplace safety. So the duty to provide adequate protection, whether that's PPE protection or literally physical protection in terms of a safe environment. And again, I'll take you back to some of the discussions that we had in the class that spoke about law, in some of the judgments that were actually provided against an organization because they did not provide a safe work environment for the nurses. And the notion that really safety is a moral obligation on a variety of levels. So nurse to nurse, nurse to patient, employer to nurse, that the expectation is that harm really must be minimized. And, there is in the interactions of how we provide care that sometimes there is some inherent harm. And, surgery, although it's done for the benefit of the patient, there is harm. You've got incisions, you've got an assault to different body systems, you've got the possibility of infection. So we really look at it in terms of the whole notion about providing safety, but sometimes in providing safety, we can cause a certain degree of harm. And I'll take you back to the Denny and Guido article that really talked about the notion of beneficence, and how important it is that continuum, if you will, that they talked about in that article about our role in really talking about preventing harm, removing harm when it's present, but also really promoting safety. And again, really seeing this as a moral obligation for nurses. And again, the whole notion, again, I'll just reinforce in terms of the safety about workplace safety, but also threats to caregivers, that we as nurses really need to foster a safe quality practice environment, recognizing that our obligation with our employers is a mutual one. And also the situation in terms of sometimes when, just because of the nature of the role that we have, that we do have an obligation to provide care when perhaps the environment is less than safe. So SARS, for those of you that remember that, the more recent Ebola outbreak. Again, so the Code of Ethics, identifies this. So you can see with point number 9, during a natural or human man-made disaster, including communicable disease outbreak, nurses provide care and the appropriate safety precautions. So the expectation is that sometimes we actually need to put ourselves in harm's way in order to provide care. So what is compassion? The notion about compassion is really about reducing or avoiding suffering for others, but also recognizing that as nurses, although our goal is to reduce suffering, that sometimes we can cause or relieve suffering through the nature of our actions. And I'll take you back to some of the discussions in DOS 1, looking at the whole notion about what is compassion, compassionate care, and what does that look like in terms of a patient's expectations and the interactions that we have with our patients. Again, what is compassion is that feeling for the pain and suffering of others and the desire to do something about that. But on the flip side, again, not losing sight of whether intentionally or unintentionally, that sometimes we can make suffering worse through the inability to provide holistic patient care. Again, I'll go back to Nicole's story as one example. The sense of not being respectful of patients' wishes, causing the loss of dignity, and recognizing that the interactions that we have with patients and the relationship that we have, our role or our goal is to truly act in their best interests. And again, here's the indicator within the code is that nurses engage in compassionate care through their speech and body language, and through their efforts to understand and care about the other's healthcare needs. So again, looking at the whole person, as well as being really quite aware about how our verbal, nonverbal behaviors can actually really demonstrate compassion, or perhaps, unfortunately, the lack thereof. This was an interesting article. It wasn't part of your readings, but this was a survey of patients in terms of what they identified as compassionate. So the study was asking patients, what was compassion to them, with what was compassionate care look like. And these are the things they identified in the study. So that notion of attentiveness, again, I'll take you back to DOS 1 and the notion of being authentically present. listening, confronting inadequacies and being very comforting at the same time, active involvement, demonstrating helping attitudes. So really, really wanting to clearly engage with the patient and assist them with whatever their needs were. Presence, I'll go back to again, and having really demonstrating a true understanding of what the patient's care needs were. So again, very similar notions, and again, the little footnote there at the bottom, I will take you back to the language of some of the theorists that we are beginning to discuss, that you began last year. So Patterson and Zadard, the whole notion about the call and response. Watson and the caring component in terms of really looking at the whole curative practices and curative processes and what that looks like. Seeing the person again as that spirit-filled individual. And really looking at the whole individual, same with, with Parsi, and looking at as individuals that they co-create the meaning and the experience. This was a nice quote again for your Art of Nursing book. So while the recognition of suffering is the first step in the dance of compassion, the second step involves a decision not to turn away, but to enter into the suffering with the patient. So to identify compassion as suffering is not enough. It is about really then engaging and making that purposeful decision to enter into that journey with the patient. So what is ethical care? It is the compassion and looking at all of these elements coming together. And it's how we then choose to behave or act in certain situations. Ethical fitness, as described in your text, really talks about to be ethically fit is to be mentally engaged in the human activity of ethical reflection and justification. So the ongoing process, not only should we be reflecting on the quality of our practice, but also to ethical reflection. To be totally engaged with what you perceive to be as the ethical dilemmas, how you're responding, what's working, what's not. So again, it requires hopefully some of the skills that you'll really start to develop throughout the course of this rest of this semester. Knowledge and skill in ethical problem solving. Engaging in ethical conduct, building that moral community with your larger members of your interprofessional team. Your text also really spoke about listening to your own voice and trusting the judgments of yourself and others. So being very self-aware, having good self-knowledge, but also self-care as well, which is really quite important. Mahatma Gandhi has a quote that the human voice can never reach the distance that is covered by the still, small voice of conscience. So listening to your gut, listening to your head, and keeping in touch with that is also part about being ethically fit. And I'll take you back to, in your readings, Nancy's story, the notion about, the struggles that she had in terms of the complexity of the care environment, trying to care for a lot of patients. Surgical patients are one thing, but then those palliative patients that really needed more of her time, and she just couldn't provide it. So for her, this was not an issue of, this wasn't a moral dilemma. She knew what was best, right, and needed, but unfortunately, the moral distress she was experiencing is because she knew what the right course of action was, but was just unable to act upon it. And in order to, defend herself, she began to become disengaged. And that is how she dealt with that moral distress in terms of looking at that particular area. And that's why it's really important to be engaged in the notion about ethical reflection as part of our ongoing fitness in terms of ethical fitness to practice as well. This is another piece of the study I wanted to share with you in terms of a long-term care study that I completed that also looked at, we surveyed registered nurses and registered practical nurses that are currently employed in long-term care. And one of the variables we wanted to look at is where were the areas of moral distress that they were experiencing. Nurses in long-term care constantly express their frustration and their inability to provide the type of care they really want to provide for the residents. So these are just some of the areas of moral distress that they identified. So on a scale of 1 to 5, they reported high moral distress related to these indicators: having to rush care because they didn't have time, seeing care suffer because there wasn't enough staff, seeing poor care because of poor communication between team members, inconsistent application of care, and then the lack of staff with that specialized knowledge to provide care, such as dementia areas. So again, looking at out of the mouths of nurses in terms of where they experience that moral distress, they know what's the right thing to do. But because of lack of resources and really intense workloads, this is the moral distress experienced by your colleagues in long-term care. Back in terms of the Pavlish article, I really liked this article as it outlined some of the early indicators of ethical issues in clinical practice. We recognize that we will continually be exposed to ethical scenarios and ethical issues, but that doesn't mean that we need to be constantly reacting to them. In a responsive way, that we can start to see through our ethical reflections and becoming more in tune to what these particular areas are, to actually start to see what are some of those early indicators where we might really experience ethical issues in clinical practice, and how can we actually start to mitigate that before they become really quite too intense. And I liked how they identified these in terms of the article, where they looked at the various indicators, such as some of the signs of conflicts, nurses objecting to some prescribed treatment, family members arguing amongst each others, nurses arguing about what's right amongst themselves. Signs of patient suffering, such as unrelieved pain, labored breathing. Signs of nurse distress being believing the treatment is futile, feeling that you're caught in the middle between different power structures. Ethics violations, violating patients' autonomy, right to information, treating patients disrespectfully. Unrealistic expectations were family dictating patient care, patients or family insisting on everything possible being done despite the futility of that, and the notions about poor communications, insensitive communication, inaccurate communications, and so on and so forth. When we start to see some of those smaller indicators, you know that that's going to end up in some type of an ethical issue. So when we start to see these things bubble up, how do we actually start to preemptively and proactively try to start to mitigate that so that we don't experience any additional ethical issues than is absolutely necessary. So I think we really have to look at how do then we use this evidence to actually, as a bit of an assessment tool, to identify where there are areas for potential conflict and ethical issues, and how do we even start to engage that conversation, make it more visible, and actually start to look at planning in a proactive, collaborative manner to mitigate some of those particular risks. So the ethics quality really, again, as I earlier discussed before, it's a single quality improvement strategy. But there's no strategy on its own that can resolve the challenge faced in nursing. So we have several documents that assist us. These codes of ethics are but one, and we really want to look at how do we try to balance what's a convex and convoluted problem of quality and patient safety, and really look at it from a multifactorial perspective. What they also talked about in your text is that really the foundation for ethical practice begins with education. So hence, as Jacqueline has already mentioned a few times, the significant importance about why ethics is a full semester course. And very often you will start to see different aspects of ethics continually woven throughout the rest of the curricula throughout your 4 years, because we really want to help you to look at ethics truly as a way of being, not just another code that has to be followed. And that through the conversations and the content we're providing you here, and hopefully the exercises and the various activities, will really help you to learn the strategies and the language that will prepare you for entering into those ethics dialogues with other healthcare professionals, as well as the realities of day-to-day practice. So I hope you found this conversation helpful. Please continue to look through the Code of Ethics as we go forward throughout the rest of the following weeks. And I look forward to looking at your reflections within the next sets of posts. Have a good day. Bye.